Dr. Sarah Deery will present on behalf of her colleagues from Johns Hopkins Hospital on the talk titled Use of Intravascular Ultrasound During First-Time Femoropopliteal Peripheral Vascular Interventions Among Medicare Beneficiaries.
Thank you for the opportunity to present this research. These are our disclosures. Intravascular ultrasound, or IVUS, has been well established as an adjunct in certain areas of vascular surgery, particularly for its use during interventions for dissection and for certain venous pathologies such as May-Thurner syndrome. However, its role in the management of lower extremity peripheral arterial disease is less known. Multiple potential benefits of IVUS have been described for the management of femoropopliteal disease, including for the use of plaque evaluation, assessment of degree of calcification, stent sizing, guiding atherectomy boundaries, and as an adjunct to confirm re-entry into the true lumen with re-entry devices. There is also the benefit of being able to reduce the contrast load and ionizing radiation when using IVUS as an adjunct to digital subtraction angiography. However, despite robust evidence for its efficacy in percutaneous coronary interventions, there are limited data regarding the use of IVUS during femoropopliteal intervention, showing that it actually improves patient outcomes. A recent meta-analysis of 8 observational studies with over 90,000 patients showed no statistically significant difference in primary patency in patients undergoing femoropopliteal interventions with IVUS as an adjunct. There was also no difference in the rate of re-interventions. We have previously evaluated the use of early peripheral vascular intervention for claudication and found wide variability across providers, with a few outliers who intervene within months of diagnosis in the vast majority of their patients. We similarly have looked at patients undergoing first-time peripheral vascular interventions and have found that multiple providers utilize atherectomy in 100% of first-time peripheral vascular intervention. Both of these practices suggest potential for overutilization. We therefore were wondering if intravascular ultrasound use was another potential area for overuse, particularly given the limited data regarding its role in the treatment of peripheral artery disease. Like atherectomy, IVUS use is well reimbursed, particularly when performed in an office-based laboratory setting, so there is a potential for overuse. Therefore, our objective was to evaluate the use of IVUS across providers for first-time femoropopliteal intervention and to identify patient and physician-level characteristics associated with the use of IVUS. We used 100% Medicare fee-for-service claims to identify all patients undergoing index femoropopliteal interventions in the year 2019. Patients with prior open or intravascular intervention by claims data were excluded. Only physicians who performed at least 10 peripheral vascular interventions during the study period were included per our data use agreement with CMS. We defined a cohort of outlier physicians as those who used IVUS more than 2 standard deviations above the mean, which corresponded to use in at least 87.5% of their cases for that year. This number was used for bivariate analyses to assess unadjusted characteristics associated with high use of IVUS. We then performed hierarchical logistic regression analysis to identify patient and physician-level factors associated with IVUS use, accounting for clustering of physicians, or clustering by physicians. We identified 58,552 Medicare beneficiaries who underwent first-time femoropopliteal intervention during the study period. Of these, 11,394, or 19%, had IVUS used during the procedure. We also identified 1,627 physicians who performed at least 10 interventions in 2019 and were therefore included in the analysis. Of these physicians, you can see that there was great variability in the use of IVUS during femoropopliteal intervention. The majority of patients, 52%, never used IVUS for FemPop interventions during the study period, and another 19% used IVUS 0 to 20% of the time. But perhaps most interestingly, 26 providers, which is just 1.6%, used IVUS during 100% of their femoropopliteal peripheral vascular interventions. Among patients undergoing just angioplasty, IVUS was used 6.9% of the time. Among patients undergoing stent placement, that number was slightly higher, with 8.1% using IVUS. However, the use of IVUS was much higher at 30% among patients undergoing atherectomy. Notably, only a negligible number of patients, less than 0.1% of the cohort, underwent both stent and atherectomy simultaneously, although IVUS use was expectedly higher than in patients undergoing only angioplasty. On adjusted analyses, end-stage renal disease was negatively associated with IVUS use. However, IVUS was more often performed in patients with claudication and was performed more often in patients undergoing stent placement and in patients undergoing atherectomy. On adjusted analyses, there were 3 physician characteristics independently associated with IVUS use. IVUS was more often used by cardiologists and radiologists as compared to a reference group of vascular surgeons. IVUS was more often used by physicians performing higher volume of femoropopliteal interventions, and IVUS was more often used by those who had a higher percentage of their practice at an office-based laboratory. In summary, we identified wide variability across providers in the use of intravascular ultrasound for index femoropopliteal peripheral vascular interventions. We found higher use for claudicants, for patients undergoing atherectomy and stenting, and in providers with higher volume and higher use of office-based laboratories. The association with these practices, particularly in the outliers with up to 100% IVUS use, raises concern that there could be overuse of IVUS among a select number of physicians. Further study of the use and the role of IVUS for lower extremity peripheral arterial disease is warranted. Thank you, and I am happy to take any questions.
Great. Great talk. Very interesting results. While we're waiting for some questions, I'll start off with a few that I had myself. Did you look at a comparison between procedures that were done in the outpatient setting in the OBL versus those being done in the hospital and see how they differed, with the thought that maybe people that were doing it within the hospital were doing it for, more quote unquote legitimate reasons? And if so, what were those reasons?
Right. We did look at location of intervention, which is what you're able to get out of the Medicare data. And the providers that were intervening in an office-based lab certainly were using IVUS much more frequently. We weren't able to otherwise distinguish whether it was an outpatient or inpatient if it was done in the hospital setting, or at least we didn't do that for this analysis.
Another question I had was, why did you think that patients that had end-stage renal disease had less utilization of IVUS? Wouldn't you expect the other way around? If people had end-stage renal disease, you might see higher rates of IVUS utilization to decrease contrast loads?
I actually had the same thought, and I think the reason for that is that the people that are already on dialysis it doesn't matter as much if you're using contrast. At least clinically, I know that's how we tend to practice. Whereas the people that have chronic kidney disease and a creatinine of 3-ish are going to be much more likely to be really trying to limit contrast use. Those are certainly the people that I've had more experience using IVUS with for these types of interventions, because we're trying to actually limit contrast use. Since we can't capture that with Medicare data, I think that's why it looks a little bit surprising.
A question from Dr. Wooster from the crowd. A number of studies have shown improved outcomes with the use of IVUS. Are we confusing overutilization with underappreciation of its value?
Yeah, I think that's a good question. I think the studies that have looked at IVUS for femoropopliteal disease tend to look at it as far as sizing for femoral stents, as well as use with atherectomy. And sometimes the data suggests that using it to size can allow for lower rates of in-stent restenosis, although these are generally pretty small series. And I think that the data in general are not very robust, and the larger meta-analyses seem to be a little bit questionable. So I think that there are some suggestions that IVUS can be helpful in certain scenarios. And I think that is an area certainly to be further studied, but I think that it would be a little bit surprising if it is a useful thing to use in all cases.
Dr. Woolhour says, great presentation. Do you think one day in the future we will be responsible for both cost and value as vascular surgeons?
I certainly think so.
And Dr. Genovese VC says, very nice talk. Did you look at long-term outcomes to compare rates of reinterventions, comparing those with and without IVUS? Less reinterventions have the potential to offset the increased costs associated with IVUS.
That's a great thought, and I think that's a good opportunity for another analysis. The cohort that we used was a cohort of patients from 2019, so we don't have long-term data yet, although I think that could be really an interesting area to look at. The one issue with that is that with Medicare data, we don't have sidedness, so it's a little bit difficult to piece out if a reintervention, even on a femoropopliteal segment, was the same side versus another side. So it's a little bit harder to determine if it's a actual reintervention for instant restenosis or just a disease on the other side.
So when you're a hammer, everything's a nail, and cardiologists use IVUS in the heart, and so they're comfortable using it. And so them using a lot of IVUS in peripheral interventions might just imply that they're using tools that they're comfortable using. Do you think that, how do you think this affects your analysis? I mean, if I get really comfortable with a tool, I tend to use it too, whether or not that's overuse, I don't know, but you just get comfortable with kind of utilizing that technology.
I absolutely think that's true. And when we looked at by provider, certainly the cardiologists and the radiologists were more often using IVUS. And I certainly think there's nothing wrong with that practice. And I think that most of that is a training paradigm difference, just like you said.
Dr. McGee has a question. If the assumption is that physicians are inappropriately using IVUS because of high reimbursements in the OBL, it would be interesting to evaluate if the people who performed IVUS in 100% of the cases in the OBL setting also used IVUS in the hospital setting, where the reimbursement rate was different. Did you look at that at all?
Well, not specifically, but I will say that the majority of the people that were using IVUS in 100% of the cases were doing 100% of their procedures in the office-based lab setting as well. There wasn't a lot of crossover. So we looked at the percent of cases done in an OBL, and those were nearly 100% in those cases as well.
Were you able to look at other characteristics of the users, such as the user's age? Do you have that kind of information, age or time of training? Did newer trained vascular surgeons use IVUS more than older physicians?
We looked at a number of different physician characteristics, such as age, years from training, region, and urban versus rural, and none of those had a significant association with IVUS use on either the bivariate or the multivariable analysis. So those factors were actually a little bit less corresponding to IVUS use than the ones that we discussed.
And then were you able in this analysis to be able to see the benefits of IVUS in regards to decreasing time of case or decreasing contrast load? Is any of that information recorded in the database?
No, unfortunately, Medicare doesn't record that type of granular data. That would certainly be interesting to know. I know that's done in some of the other smaller series, but not something that we're able to look at.
Great. We'll go ahead and move on to the next talk. Great job.